You so much, Dan. That's very kind of you. Can everyone see my screen? I'll take that as a yes. And let's see. All right. So I'll take us through understanding the Lewy body dementias. And there have been a few people in recent years who have brought a face to the disease: Bill Buckner, Robin Williams, which is, I think, really important, particularly because this is actually, quite common illnesses that have been, I think, overlooked to some degree for too long. So with respect to the overview, I'm going to start with a primer on thinking, just so we're all on the same page with some of the language, a bit of gobbledygook that we'll all get under our belts. And then I'll tell us about conditions that fall under the umbrella term Lewy body dementias, describe steps involved in diagnosing these conditions, and then move into talking about treatment strategies and some research updates. Of course, these are big topics. We have only limited time, but we'll certainly cover these areas. With respect to thinking, it's worth pointing out that thinking is a complex process, and really there are multiple domains that contribute to thinking that we all use all the time in order to think well. And it turns out that different regions of brain subserve different domains of thinking. And so it is useful for us to think about this, and different diseases will impact each of these domains of thinking differently. Attention, of course, is very important. Your ability to, for example, to attend to what I'm saying. Your ability to remember what I've said later today and tomorrow. Short-term memory, long-term memory, completely different region of brain, different substrate, but a very important component of thinking as well. Language is worth emphasizing. Your ability to understand what it is I'm saying, and my ability to speak fluently and choose my words appropriately. Visual spatial skill, another important domain. Our ability to navigate in the world, to find things in a crowded environment like a fridge. Response speed turns out to be important as well. It's one of several domains impacted in these diseases. Procedural memory, this refers to the ability to recall motor tasks such as riding a bicycle. Tool use, a hammer, a knife and fork. Executive function, a complex concept that includes things like planning and multitasking and judgment. So each of these are important domains of thinking, worth keeping in mind as we delve in. So what is dementia? We think of dementia as cognitive decline, usually progressing slowly, but it could occur rapidly, but impacting thinking both subjectively and objectively. So the patient is aware that thinking has changed, and the doctor can corroborate that in the office. With any of these domains involved, it need not be all or one, but a domain of thinking and impacting in our function, and ultimately sufficiently interfering with our function to impact our independence. It's that loss of independence that leads to a diagnosis of dementia. While we're still independent, we use other terms like mild cognitive impairment. And it's important to keep in mind that when we think about dementia, that we need to have no obvious explanation, like an infection that could make us confused, or a medication side effect, or the like. So this is dementia, and there are multiple causes of it. And we'll be talking about the Lewy body dementias today, which turns out to be the second most common of the neurodegenerative dementias after Alzheimer's disease. We're going to start with the dementia that arises in Parkinson's dementia. And for that, you'll need a primer on Parkinson's. Parkinson's disease, it turns out, is the second most common neurodegenerative disease after Alzheimer's in its own right. And it affects some 1% of the population above the age of 50. In his famous essay on the shaking palsy, written by James Parkinson back in 1817, James Parkinson described the key motor features. And I don't know if you can see my mouse or not, but he talked about tremor, tremulous motion. He talked about postural changes, bending the trunk forwards, walking changes. It turns out that he made he did very, very well for 1817, and for his first assessment, just from watching people walking the streets of London. But it turns out he was wrong when he said the senses and the intellects are uninjured, because they often are impacted. With respect to signs of Parkinson's disease, the key motor features are a resting tremor, stiffness in an arm or a leg or a neck, motor slowness, so-called bradykinesia, and changing of walking. We might shuffle, walk more slowly, have difficulty with our turns, or freeze. These are the key motor features that lead doctors to make, along with examination, lead to the diagnosis. But non-motor problems are common as well. We'll be focusing on thinking today, cognition. Those are common. Sleep changes are common too, and problems with the autonomic system, such that can lead to problems like constipation, urinary problems, and blood pressure issues arise commonly too. It turns out that cognitive symptoms, trouble thinking, accumulate as Parkinson's progresses. There's a staging system for Parkinson's, so-called Hoehn and Yahr staging system. It goes from stage 1 to stage 5. Stage 1 is early disease. One side of the body might be involved. By stage 2, both sides of the body are involved. By stage 3, we're starting to lose our balance, but we're doing all right. By stage 4, we're now wheelchair dependent. And it turns out that trouble thinking, the likelihood of having trouble thinking, doubles from 40% at stage 1 to 86% by stage 4. And any of these domains listed on the left might be involved, whether it's executive function or memory or visual spatial function or attention or slowing of thinking. And often more than one is involved at the same time. And in this context, it turns out that dementia in Parkinson's disease is common. About 1 in 3 people with Parkinson's disease are living with dementia. And that translates to a risk of dementia in Parkinson's around 3-fold higher than in the non-Parkinson's population. So Parkinson's itself is a risk factor for dementia. And if you take all comers living with Parkinson's disease, around 1 to 10% per year will convert to dementia. In our experience, it's on the order of 4% here in Boston. It turns out that behavioral features are commonly associated with Parkinson's dementia as well. Apathy is common. Anxiety and depression are common. Hallucinations are common as well, and I'll emphasize them for a minute. They're often visual hallucinations, animate people, animals, not typically scary, but they can be. But they're a common feature that arises in Parkinson's dementia as well. False beliefs might arise, so-called delusions. Excessive daytime sleepiness is not uncommon, and there's a phenomenon where we do lose our normal paralysis of REM sleep. REM sleep occurs late in the night. Our bodies are paralyzed and our eyes go back and forth. Rapid eye movement sleep is what that refers to. And in REM sleep behavioral disorder, we lose that normal paralysis. We might act out our most exciting dreams, occasionally hurting ourselves or a bed partner in the process. And it turns out that REM sleep behavioral disorder, or RBD, is not just common in the context of Parkinson's dementia, it's common in Parkinson's, and it can even antedate Parkinson's disease by many years. It seems to be a risk factor for developing Parkinson's altogether. Well, let's contrast what I've told you with Parkinson's disease and Parkinson's dementia with Lewy bodies. And this is Frederick Lewy, who described the Lewy body. And again, if you can see my cursor, you can see the pink circle. This turns out to be a pink sphere inside a cortical brain cell. This is the classic Lewy body. The Lewy body, it turns out, is present not just in dementia with Lewy bodies, but also in Parkinson's disease. And in fact, for all intents and purposes, neuropathologists can't differentiate a Parkinson's Lewy body from a dementia with Lewy bodies, a DLB Lewy body. They're both comprised of the same protein, alpha-synuclein. And we'll come back to that point later. With respect to the clinical features of dementia with Lewy bodies, you're going to find they're very reminiscent of what I've told you about in Parkinson's dementia. We have progressive cognitive impairment, variety of domains often involved, executive function frequently involved, planning, multitasking, short-term memory may be involved, visual spatial function can often cause trouble People might get lost more than before, for example. Attention may be impacted, and we may slow down in our speed of thought, so-called bradiphrenia, just like in Parkinson's dementia. And it's not at all uncommon in dementia with Lewy bodies to see people develop motor symptoms of Parkinsonism, the same motor slowing that we talked about before. There may or may not be a tremor, there may or may not be stiffness and walking changes and the like. The Parkinsonism motor changes don't have to arise, but they commonly do. Likewise, REM sleep behavioral disorder is commonly present in these people as well, and it may antedate the illness by several years. Again, it's not necessary for the diagnosis, but it is common. My slides appear to be timed, so if it jumps ahead, it's not me. Visual hallucinations are common as well, and it turns out these are, again, animate, typically people and animals, typically not scary, but they can be. And one feature that's worth emphasizing that is a little bit distinct of this concept of cognitive fluctuations, and this is significant variation in the level of alertness or the ability to focus over the course of the day or day to day. On the time might be a time scale of hours or minutes or days, so-called cognitive fluctuations. In order to diagnose these conditions, patients will see their doctor, be referred to a general neurologist, and they may refer on to a subspecialist, or they might go ahead and make the diagnosis themselves through a careful clinical examination, sticking to criteria that we'll talk about soon. We'll use blood work to exclude other diagnoses. We'll use brain imaging, again, to exclude other diagnoses. And there are specialized tests we may implement to hone in on the diagnosis and make sure we're not missing anything. With respect to the specific criteria for Parkinson's dementia, this requires slowly progressive cognitive decline in the context of well-established Parkinson's disease. That's really the key, arising after more than 1 year of straightforward, idiopathic, regular old Parkinson's disease. Attention, executive function, memory, and language are commonly affected. Hallucinations, delusions, apathy, depression, anxiety commonly arise, but need not. But this is the key, that you've got regular Parkinson's disease, well-established, well-diagnosed, and then trouble thinking arises. And there aren't other explanations like medications, for example. And we'll come back to that concept soon. There are some risk factors for developing dementia in Parkinson's disease. This includes unusual presentations of Parkinson's. For example, if the disease doesn't involve a tremor or if there's early postural instability. The presence of early hallucinations in its own right is a risk factor. Doesn't guarantee progression to dementia, but it's a risk factor. Greater motor impairment, a longer duration of illness. These are also risk factors. Older age is a risk factor as well. Being a man as well, and having mild cognitive impairment. Having some trouble with thinking to begin with is a risk factor for progressing in Parkinson's. Well, let's contrast what I've told you with what's required to make a clinical diagnosis of dementia with Lewy bodies. Here again, we require the central feature of progressive cognitive decline that's sufficiently severe to interfere with our daily function, so it's dementia. And we have these core features that I've touched upon before, the motor manifestations of Parkinsonism, the visual hallucinations, the fluctuations of thinking, and the acting out our dreams at night, the REM sleep behavioral disorder. It turns out if you have 2 of those and the central feature, you meet clinical criteria for a diagnosis of probable DLB. If you only have 1 of those 4 core features, if you can still make the clinical diagnosis, doctors like me can still make the clinical diagnosis if there's evidence of an abnormality in one of these biomarkers listed below. That includes something called a DAT scan, which looks at the integrity of the dopamine system. I'll show you a picture of something like that later, but because dopamine cells get sick in dementia with Lewy bodies and Parkinson's disease, being able to visualize them and demonstrate loss of dopamine can be very helpful for making the diagnosis. There's another scan called an MIBG scan, which actually looks at the innervation of the heart by the sympathetic system. It turns out that when that's abnormal, that's also a risk factor for DLB. It's often impacted in DLB. And then if a person undergoes a sleep study, we can get hard objective evidence of the REM sleep problem. It's called REM sleep without atonia that we would see on the sleep study. The other key feature for making this clinical diagnosis is to think about the timing of cognitive impairment relative to motor impairment. Cognitive impairment has to arise early relative to motor impairment to make the diagnosis of dementia with Lewy bodies. And from what I've told you, you can see that it's worth thinking about dementia with Lewy bodies and Parkinson's dementia perhaps as two ends of the same spectrum. In both cases, the patients develop dementia, Parkinson changes, motor changes, visual hallucinations, and the REM sleep behavioral disorder problem of sleep. The difference really is in the timing of dementia onset within 1 year of Parkinson motor signs for DLB versus Parkinson's dementia, where dementia onset occurs later, at least 1 year after the development of Parkinson motor signs. And that's really how doctors by fiat will differentiate these illnesses. But like I said before, in the brain of these patients, we see Lewy bodies, we see the same neuropathological process. And I think it's worth keeping that in mind, because I think my bet is that a cure for one will be a cure for both. Let's talk about the accuracy of DLB diagnosis. It turns out that that accuracy very much depends upon the practitioner. People who are used to using these criteria and are good at it actually have quite a high clinical accuracy, well above 85–90%, just using these clinical criteria, and that's pretty good. It's not perfect, but it's pretty good, and those numbers fall quite a bit when people without a lot of expertise attempt to employ them. That said, it's not perfect, so even in the best of hands, there is a risk of an incorrect diagnosis, and of course, we want to get the diagnosis right. It can be stressful, of course, to patients and families to have the wrong diagnosis. But there are also clinical repercussions. It turns out there are some medications that are quite dangerous in patients with dementia with Lewy bodies and Parkinson's dementia, so-called neuroleptics. And we'll touch upon that a bit later. There's also lost opportunity for treatment because there are a lot of good pharmaceutical and non-pharmaceutical strategies to treat patients with DLB and Parkinson's dementia both. And there's also the issue of inappropriate exclusion from and inclusion in clinical trials. And that's important. If we want to get a drug to market that's going to beat dementia with Lewy bodies, we've got to make sure that people in the clinical trial have dementia with Lewy bodies, for example. With respect to symptoms and treatment of PD, dementia, and dementia with Lewy bodies, for trouble thinking, we have in clinical use, two major strategies. One is to use a class of medicines that increases brain acetylcholine. These are so-called choline esterase inhibitors, like donepezil or rivastigmine or galantamine. They can be quite effective in this setting, as I'll touch upon shortly. Memantine can help some patients as well, and is good clinical evidence for its benefit too. For motor symptoms of Parkinsonism, the mainstay is to increase dopamine in the brain because it's the loss of dopamine that contributes to these motor symptoms. And we do that using carbidopa-levodopa, which is a medicine that brings levodopa to the brain that then gets turned into dopamine. That helps some patients, not all, but it certainly does help some patients quite a bit. There's another medicine called zonisamide that could be helpful too. There are also non-pharmaceutical strategies that are really important in these illnesses. Physical therapy is incredibly valuable for fall prevention, and exercise in its own right goes such a long way in helping with these motor changes. Occupational therapy is important as well. It can play a real role in optimizing life skills and life function using a knife and a fork if a tremor is bad, that kind of thing. Speech therapy plays an important role too in helping us speak more loudly if our speech is growing soft, which it can in this context, both with Parkinson's and with DLB. And then speech therapy also plays a role in the context of trouble with swallowing that can arise late in the disease, in the context of working hard to prevent any kind of an aspiration bringing food down the wrong tube and putting us at risk for pneumonia. There are medication strategies that can be quite effective for treating the acting out the dreams at night if it requires treatment. Sometimes it doesn't, but occasionally people can be violent enough to hurt themselves or their bed partner, and then we can use melatonin or clonazepam or like strategies. It turns out that visual hallucinations, when they're mild and occasional and not scary, they don't really require a whole lot of pharmacological management. Luckily, they tend to get a whole lot better in some people with acetylcholinesterase inhibitors. So the same medicines we'll use to help with thinking can help with hallucinations. However, if need be, we'll bring in other medications. Quetiapine, something known as Seroquel, clozapine, known as Clozaril, pimavanserin, known as Nuplazid, are agents that can be quite helpful as well. These medicines, particularly the quetiapine and clozapine agents, are in the class of, well, yes, all three are antipsychotics, but the quetiapine and clozapine are an older class of antipsychotics, and they turn out to be the safer of the antipsychotics that are available. There are some other antipsychotics, plenty of them, that can be quite dangerous. And this gets back to the point I was making earlier about neuroleptics, which is also known as antipsychotics, and some of those can be very dangerous, both in Parkinson's disease and in dementia with Lewy bodies. And the classic one that can cause a lot of trouble is Haldol, haloperidol. Another one is risperidone. These agents can be really problematic. They can cause something called neuroleptic malignant syndrome, which can make people very sick indeed. They can irreversibly worsen the motor problems of Parkinsonism, and they can also increase mortality. And so, for my patients who have Lewy body, I sort of ask them to keep in mind that they're effectively allergic to haloperidol. It's just worth keeping that in mind. Occasionally, if a patient's hospitalized for one reason or another, occasionally patients will get confused in that setting. And if they have dementia with Lewy bodies, they're much more likely to be confused. Likewise, Parkinson's disease, dementia. And doctors are much more cognizant now than they used to be to avoid these kind of medicines in patients with Parkinsonism. But I think it's good for patients to be aware as well. With respect to this issue of why we use cholinesterase inhibitors, these are sort of key clinical. Actually, at the bottom is a key clinical trial in Parkinson's dementia compared to a key clinical trial of rivastigmine and Alzheimer's disease. And to make an important point, I think, and that is in the clinical trial of Alzheimer's disease, if you can see my cursor, the patients who got placebo got worse over time. The people who got the drug more or less stayed stable. Clear benefit, real benefit. But the patients themselves didn't notice a whole lot of a change. In contrast, in the Parkinson's dementia trial, the people who got the placebo more or less stayed stable. The people who got the drug, on average, tended to notice. They tended to get better. There's a lot of variability in the response to medicines like rivastigmine and donepezil, but some patients really do notice the improvement, and I think it can be quite helpful in this context. Now, many medications can worsen thinking reversibly. And a lot of those medicines are used to treat Parkinson's disease. And this is not a talk on Parkinson's, but I just list here a lot of medicines that Parkinson's patients are frequently put on. And as cognitive impairment arises later in the course of Parkinson's, people have to take these medicines away. Doctors have to be aware, take them away, and sometimes that's all it takes. Then people can think well again. Outside of the Parkinson's medications sphere, there are a variety of medications that doctors will prescribe to us in later life, and that can cause reversible but important trouble with thinking. It turns out that other medicines that do the opposite of what rivastigmine does, that they're so-called anticholinergics, they block the cholinergic system, like amitriptyline. Trihexyphenidyl is another one. These agents can cause trouble, and they have been used for mood, they've been used for sleep, so it's worth keeping that in mind. It's not a surprise, perhaps, that pain medications like opiates might cause confusion. Muscle relaxants, likewise. Certainly, if you're in pain, it's really important that we treat your pain appropriately. But we want to use the lowest dose that does the job to help people to think as well as possible. And then there are a variety of anxiety and sleep medications that can cause trouble too. Benadryl is a classic example. It's the major ingredient in Tylenol PM and a lot of these over-the-counter sleep aids, and it's very, very good at causing confusion. Ambien likewise can cause confusion, and so can a variety of medicines called benzodiazepines as well in more frail patients. So we want to avoid them. Now, it's worth just emphasizing, you might have seen this before, there are a number of potentially modifiable risk factors for dementia, and they apply to all patients, all people, I should say. We know that people with a greater education have a relative reduced risk of developing dementia later in life, and that's an early life exposure. In midlife, optimizing hearing, optimizing blood pressure, optimizing weight and sleep appear to be important as well, because that's associated with reduced risk of dementia later in life. And in late life, above the age of 65, quitting smoking, optimizing mood, staying socially engaged and physically active, treating diabetes aggressively, all appear to be important as well in reducing the risk of dementia. These are just based on epidemiological studies, not from any kind of careful study of people who smoke versus non-smoke followed over 30 years. But the data are pretty compelling nonetheless. And these are things we can all do. And I'll transition from here to research updates, focusing a little bit on really some interesting new ways to make an accurate diagnosis, both of Parkinson's disease and dementia with Lewy bodies. Talk a little bit about molecular imaging and briefly touch upon clinical trials for DLB. You might have heard in the news some real progress in the diagnosis of these illnesses based on something called a seed amplification assay. And the idea is to take a small sample, for example, from the spinal fluid, the cerebral spinal fluid that bathes the brain, or even from the skin, from a skin biopsy. And it turns out that with this very small sample, there might be the idea is to take and amplify up a very small amount of the alpha-synuclein seed protein, not the individual molecule, but the aggregated molecule that's aggregating in the context of disease. And shown in red here is the amplification process compared to a normal person. And it does a really nice job. Parkinson's and Lewy body overlap in the assay. They look very, very similar, and that's not surprising because they share the same hallmark neuropathology, the Lewy body, in the brain. It turns out that we've already gotten some longitudinal data in folks who have an abnormal test compared to normal people followed in green here. The people who have the abnormal Lewy body test decline over time. People who are cognitively normal at baseline will nonetheless develop trouble thinking over time. So this does appear to be an important tool. And people who were cognitively normal at baseline and had not just an abnormal Lewy body protein on this test, but also evidence of Alzheimer changes, they decline the fastest. And we'll come back to this idea of copathology shortly. Moving to another tool that's recently been in the news, there was a paper in JAMA Neurology that got some press about another skin biopsy approach for the diagnosis of Parkinson's. And it turns out it does really equally good job for the diagnosis of dementia with Lewy bodies and another disease called MSA. Multiple systems atrophy. And the idea here is that you can use regular old histology staining methods to detect the alpha-synuclein in the nerves of the skin. And that's what's shown here in green. People have been doing this for the last several years, but the press came out because now it was a much larger study that showed that this appears to work quite well. And so, and this is already entering the clinical arena. And so is a spinal fluid attempt, a tool. The problem is getting it covered, getting these covered by insurance is not 100%. It's quite good, but not 100%. But we're getting there. Well, what about being able to do a brain scan to look at the Lewy body? This is something that many groups, including our own, are after. And we think it'd be useful not just to make a binary diagnosis as these tools do, but rather to be able to see the Lewy body accumulation over time and to intervene, to use that for clinical trials to see if we can make the Lewy body proteins disappear. It turns out that mixed pathologies are common in the Lewy body dementias. We've talked about the Lewy bodies, and we've talked about dopamine cell loss. it turns out that Alzheimer changes are common too in the form of amyloid plaques shown here in a little brain section, along with tau tangles that show up inside brain cells. They're variably present, but not uncommonly present in people with dementia with Lewy bodies and Parkinson's dementia. And we and others have been exploring for some time now and finding strong evidence for repercussions of having mixed pathology. With respect to imaging the dopamine system, I mentioned the DAT scan before, and that's an FDA-approved approach used in the clinic all the time. There are higher resolution approaches, such as this PET scan approach that we've employed. And normally we see good signal in this deep area of the brain called the striatum, where the dopamine cells send their synapses. And in people with Alzheimer's, it's also intact. But in people with Parkinson's and dementia with Lewy bodies, as the dopamine cells are lost, we can see that in the scan. And it turns out, that we can differentiate dementia with Lewy bodies from Parkinson's by looking at the pattern of the signal loss within this area of the brain called the striatum. Amyloid imaging has been around for a while now. We were among the first to explore it in folks with Lewy body and Parkinson's. And in Alzheimer's, the brain sort of lights up like a light bulb compared to most people who are of similar age. But not all, for what it's worth. In Parkinson's disease, cognitively normal people will typically not have a whole lot of amyloid changes. In Parkinson's dementia, it's not uncommon to see some foci of elevated amyloid, and dementia with Lewy bodies, on average, will see quite a bit of amyloid burden. Not always, it's say 2/3 of cases or so. And it turns out there are clinical repercussions of this. The people with the highest amyloid burden convert the most quickly from cognitively normal to cognitive impairment and dementia compared to the folks with the lowest amyloid burden. So it is clinically meaningful. And the people with the highest amyloid burden also progress the fastest on measures of cognitive function as well. And that's true both in dementia with Lewy bodies and Parkinson's dementia. We can look at tau as well in the brain using imaging, and we'll find that it's not uncommon to see some level of tau burden in folks with dementia with Lewy bodies and cognitively impaired Parkinson's disease, absent in cognitively normal Parkinson's. These levels, even in dementia with Lewy bodies, are lower than we see in Alzheimer's, but they are there, and it turns out that their level is proportional to the amount of cognitive impairment in these patients. So it's, I think, a worthwhile target as well. With respect to clinical trials, most trials to date have been focused on symptom management, but there are a few exceptions. For example, there's a clinical trial underway right now called REWIND-LB, which is a phase 2b study of a drug called neflamapimod. The phase 2a study was promising, and we and others are active study sites for this study. And if this is successful, it'll result in a phase 3 and hopefully FDA approval. But I think it's an interesting drug that designed to improve thinking in this disease. In the context of the recent FDA approval of lecanemab to remove amyloid from the brain so effectively in Alzheimer's disease, you might recall that there was dramatic loss of amyloid, appropriately incremental but meaningful improvement in the rate of cognitive decline in people with Alzheimer's, but not quite as dramatic, unfortunately. Nonetheless, this has raised the specter that it's entirely possible that removing amyloid and, for that matter, tau from the brain might be useful in folks with Lewy body dementia who have amyloid and tau burden. Likewise, targeting synuclein, as is the Lewy body protein, I think is going to be important as well. And this is a target of Parkinson's disease right now. We really need trials in dementia with Lewy bodies and Parkinson's dementia as well. And the point here is that many trials now underway, if effective, may well extend to dementia with Lewy bodies. One more point I'll make is that if you take all comers who signed up for a brain autopsy, and you look at the folks who had advanced dementia here on the bottom right, late dementia, you'll see many of them had Alzheimer's, shown in blue. Many had stroke-like problems, vascular problems, shown in red. Many had Lewy body changes, shown in green. And now I want to contrast that with the top left. These are people who died while perfectly normal cognitively. These guys were doing very, very well, and they underwent autopsy. And it turns out that it's not uncommon to see neuropathologic changes in them. When you see them, this is what you see. You see some Alzheimer changes, some vascular changes, and in green, some Lewy body changes as well. And what that means is it's possible to live with these changes of Alzheimer's, vascular problems, and Lewy body, and yet be cognitively normal. So some of us are able to do that. And we don't yet understand what allows these people to tolerate these microscopic pathologies, but they do. Is it related to cognitive reserve? Is it related to mitigating these risk factors I touched upon earlier, optimizing sleep, not smoking and the like? We don't know. And this is a big research question too. So I'll just acknowledge my colleagues and collaborators, and especially all the research participants and their caregivers who contribute so much to our understanding of Parkinson's dementia and dementia with Lewy bodies, and to our efforts to come up with new treatments for them. Thank you.
I'd like to thank Dr. Gomperts for helping us better understand the Lewy body dementias. And I'd also like to tell you briefly about my own story. That began around 2010 when I noticed my memory declining, and that it was doing so at a faster clip than I think those people my own age. And in 2012, in December, I had a neuropsych exam, a full one, and came back fine, said that I was weakness in a few areas, but normal aging explained it. And not to worry. However, I did keep on worrying some. And in 2022, a decade later, I had another neuropsych exam because I was still worried. And that came back that I had mild cognitive impairment, but the neuropsychologist said I definitely did not have Alzheimer's or any other dementia, including Lewy body disease. So a couple of other incidents happened over the next 8 months. And I decided I would see a neurologist. And in March of last year, I had saw the neurologist who examined me carefully, and she suspected that I might have Alzheimer's disease and also Lewy body or Parkinson's. So I had a lumbar spinal tap for some cerebrospinal fluid, and that came back with really bad biomarkers for Alzheimer's. On the tau protein, I was actually off the chart, and which was really quite disturbing. And I had a DAT scan to look at dopamine transporter issues, and that was somewhat indicative of having Lewy body disease. And more recently, I had an interesting series of skin biopsy tests of my neck, thigh, and calf, which came back positive for alpha-synuclein, which is one of the hallmarks of both Parkinson's and Lewy body, and helped confirm with a number of other symptoms that I had Lewy body disease. And how was my reaction to all this? Well, not surprisingly, it felt like the worst thing that could possibly happen to me. So the prospect of losing my mind. I was filled with terror, depression, anxiety, but it didn't last long. And I'm not exactly sure why, but about 10 days later, I awoke one day and I said I had a new purpose in life. And that was to help remove the stigma surrounding Alzheimer's, Lewy body disease, and other dementias, and to help those with the disease to be open about it and proactive about getting help. What have I done for myself? Well, on rivastigmine to help with the dopamine issue, and I'm doing all that I can to slow the progression of the disease. Vigorous exercise. I love playing squash and tennis. Social engagement with my friends and families. Eating well through the Mediterranean diet, except that I absolutely refuse to give up ice cream. And then fulfilling my purpose of involvement with dementia organizations through activities like this talk. And I'm doing work with the Alzheimer's Association and the Dementia Solutions Group at Brigham and Women's. And how am I doing in terms of my own sort of psyche? Well, in many ways, I actually feel better than ever. I certainly don't feel like anybody needs to feel sorry for me. And I did make a solid decision to have hope, even though the biomarkers are not looking very good. And what's given me reason to that is a variety of things. One, first of all, I've read the research, and having hope is generally good for your mental health, and there's evidence that it will help slow the progression of the disease. In the second, in 5 years, if I was still functioning well and not having much of a memory decline or any other symptoms, and I had spent that time worrying and being depressed about it, what a waste of time. I might as well be happy. I might as well have been happy and enjoying it. And it's really helped me live in the present. So in that ways, Alzheimer's has actually helped me. There's a couple of other reasons. One is very idiosyncratic. In 2017, I had sudden cardiac arrest, and research says there was about a 1 in 1,000 chance of my surviving without brain damage. But I did because I was very lucky. I got CPR within a minute, and the EMTs arrived to start my heart back with a defibrillator. There's also the fact I have a world of people involved in Lewy body and Alzheimer's care who I think have been wonderful and have given me a lot of support. And at the Massachusetts Alzheimer's Disease Research Center, I'm in the longitudinal cohort study, and that has been a great community and very supportive for me, helped keep me abreast of latest developments. And for any of you concerned about dementia, enrolling in a clinical study is a great way to get access to the latest potential treatments by getting involved in a clinical study. I'd like to thank the Massachusetts Alzheimer's Disease Research Center for the opportunity to be a research fellow and to talk with you today. Thank you so much.